Do you know what the number one risk is for cancer survivors? It's not cancer. For many of them, it's heart disease.
Early cardiac damage can be silent. You don't usually feel any symptoms from cardiac damage until you have overt heart disease.
What are the ways patients should be advocating for surveillance?
So really the screening depends upon what the toxicity is.
There are things we can do. There are things we can look for. There are things we can ask for. There's ways we can change our lives to mitigate that risk. And today's guest, Dr. Anju Nohria, the cardio-oncology director at the Dana-Farber Cancer Institute, is going to explain it all so you can take action.
That was the first trial that has shown that regular exercise can actually improve your likelihood of having recurrent cancer and dying from cancer.
We fight to clear our bodies of cancer. We take poison, we burn the cells, we cut. But what if the cure that saves your life is quietly threatening your heart? Today, we're looking at the curveball that too many survivors don't see coming until it hits them: cardiotoxicity and the cardiac implications of cardio-oncology. If you're currently in treatment or already rung the bell, you need to know how to protect your heart. My guest is Dr. Anju Nohria, the director of the cardio-oncology program at Dana-Farber and Brigham and Women's Hospital. She's an expert at the intersection of saving your life and saving your heart. Anju, welcome to Kicking Cancer's Ass.
Thank you for inviting me. I'm delighted.
Great. All right, well, let's jump into it. Many of us feel like we're making a deal with the devil during treatment. Kill the cancer, whatever the cost. But you work in that cost department. Can you explain in simple terms why certain cancer treatments decide to pick a fight with our heart?
So some cancer treatments are very effective because they kill rapidly growing cells, which is what cancer cells are. But unfortunately, they're not very selective. And often they can also damage other bystander cells, including the heart. Unfortunately, the heart does not regenerate or repair itself very well. And therefore, even if you have small damage over time, that can cumulatively affect the heart. So drugs such as anthracyclines, namely doxorubicin, epirubicin, etc., or even radiation therapy, especially if you are radiating parts of the chest where the heart could be in the radiation field, such as the left side of your chest. You can develop things called oxidative stress. And this oxidative stress partly kills the tumor, but can also damage the heart, the blood vessels, the valves, etc. And that's why certain cancer therapies are more prone to causing cardiac dysfunction. Even some of the newer cancer therapies, namely targeted therapies, affect certain pathways or chemical pathways in the cancer cell that are important for the cancer to grow and replicate. But these pathways can also be important in the heart for normal growth and replication of the heart. So you can end up getting some damage to the heart because those pathways, again, are not specific to the cancer. And that's why some cancer therapies end up causing cardiac damage.
All right. And so, we all think of nausea, hair loss, fatigue as the side effects. What does heart stress look and feel like during chemo or after? Is it something we can feel? Is it silent until it's dangerous?
So often, early cardiac damage can be silent. You don't usually feel any symptoms from cardiac damage until you have overt heart disease. So often people won't realize that they're having cardiac damage, which is why knowing about it and doing routine surveillance is so important. By the time you have significant heart disease, you often feel symptoms like shortness of breath, chest tightness, fatigue, things that are very hard to distinguish when you're having cancer, because you can be fatigued, you can be short of breath, you can have chest tightness. All these things can happen as a consequence of the cancer itself. Many patients will have a rapid heart rate and then they feel palpitations or tachycardia. But the problem is that could be stress just from knowing that you have a diagnosis. It could be infection. It could be deconditioning. So there are many reasons why you can have these symptoms, and that is why surveillance is so important.
What are the ways patients should be advocating for surveillance during and after they've gone through treatment in order to detect any kind of heart damage early enough to intervene? And are there interventions?
So it sort of depends on what you're being treated with. So, not every cancer therapy is toxic to the heart, right? So, first of all, you have to know whether or not the treatment that you're getting causes any kind of cardiac damage. If it does, then there are guidelines for how you should be monitored in those situations. So, for instance, if you take anthracyclines or doxorubicin, it is a very well established drug that can cause heart damage. Whether or not you get heart damage depends upon the dose that you're being given. It depends on your age. It depends on whether or not you have pre-existing heart disease or well-known traditional cardiac risk factors, such as high blood pressure, high cholesterol, diabetes, etc. And the protocol for surveillance really depends upon all of these factors. So if you know, the first thing a patient could do to advocate for themselves is to find out from their oncologist what are the potential side effects of the medications that they're getting that could have long-term implications, so beyond nausea, vomiting, diarrhea, hair loss, etc. If they mention that the heart is such a potential organ that could be damaged, then you could ask, am I being screened for that, right? And if so, how often, what is being done? And then really you have to, at some level, take ownership to make sure that that happens. And how you get screened really depends upon what the particular toxicity is that that drug causes. So for instance, in the case of anthracyclines, they weaken the heart muscle. So then you want to be getting an echo before, during, and after chemotherapy. And how long after really depends upon the age at which you were treated, because children are more susceptible and have to have lifelong surveillance. Adults only need surveillance for a couple years after they finish chemotherapy. Radiation is a long-term cardiotoxicity, and often the effects don't even show up until you're 10, 20, 30 years out from radiation. So those patients need also lifelong surveillance. Targeted therapies like trastuzumab or Herceptin usually cause cardiac dysfunction while you're getting treated. So you only need to be monitored while you're going through therapy and maybe for a year after. So again, the duration varies. It depends on what the side effects are and, who you are going into that treatment.
Does the heart repair itself if it has been, damaged?
So certain chemotherapies cause or cancer therapies cause irreversible damage. So like anthracyclines can cause irreversible damage, but if you detect it early and act quickly, you can redeem the heart in some cases. Other therapies like Herceptin, for instance, tend to cause more dysfunction than permanent damage. But again, there, if you get to it early and you treat those patients early, most of them will recover. Radiation tends to cause irreversible damage, by the time it happens. So it depends on the therapy. It depends on what it is. But again, in most cases, if you catch it early, you have a greater chance of preventing irreparable damage than if you catch it once the disease has really progressed.
And that makes sense. Now, I saw last year at the Rise Up for Breast Cancer conference, a talk on doing radiation with the patient sideways so that you could radiate the breast without the heart being in the zone. Is that a common approach to try to mitigate the lifelong implications of radiation on the heart?
So breast cancer therapy has really come a long way, because we know that radiation to the heart can be harmful. The breast radiation oncologists have really come up with many, many techniques for radiating the breast that do not involve a large portion of the heart. So for instance, something simple like a deep breath hold, where they ask you to take a deep breath in while they do the radiation, moves the heart away from the chest wall and allows you to prevent the heart from being in the radiation field. If you have really pendulous breasts, you can lie in a prone position, where you're face down, and that swings the breasts out and away from the heart and allows you to be radiated. What you were talking about is what they call tangential beam radiation, where it's coming from the side, and you avoid the heart. So there's many, many ways, even in things like lymphoma. Previously they used to do like mantle radiation, all the way from your neck down to your like belly button almost, or xiphoid. Now they do, involved node radiation, involved field radiation. They only radiate where the disease is as opposed to the whole chest. So all these things have improved your risk from radiation. One of the bigger developments is proton beam therapy. So that's different from traditional photon beam therapy. And in proton beam therapy, the penetration to other organs is less. So hopefully that'll translate into less cardiac dysfunction. The problem is that, the technology is moving, but because the disease only manifests 20, 30 years later, we don't know how successful these changes are going to be. But the hope is that they will reduce long-term cardiac side effects.
Okay, so I have to bring up another group that is not getting long-term research, which are the people, women, overwhelmingly, who either do prophylactic surgery that puts them into early menopause, or their treatment put them into early menopause, and they are deprived of estrogen for anywhere from 10 to 15 years. This is obviously personal for me because this has to do with my cardiac health. But what should that group of women, they're young women, and they're hoping to be alive for 50, 60, 70 years. And I think you said the leading cause of death for cancer survivors is cardiac.
Other than cancer, yes. So the leading cause of non-cancer death in cancer survivors is heart disease. So I think as you correctly point out, especially if you're under the age of 45 and you either have a surgical, removal of your ovaries or shutdown of your ovaries prematurely because of cancer treatment, you do have a slightly increased risk of heart disease. And that's because estrogen is so important for making your blood vessels flexible. It's important for cholesterol metabolism, etc. So I think that what those women have to do is be very, very proactive about making sure that their cardiovascular risk factors are monitored and treated appropriately, right? So normally we don't think of ourselves as being at risk for high cholesterol or diabetes or high blood pressure when we're in our 30s and 40s, right? But if you've had premature ovarian failure, right, because of your treatment, then you should be monitored for those things and treated aggressively. Also, depending on what kind of cancer you had, right, you may be able to take estrogen supplements. Not every cancer is a complete no-no for estrogen supplementation. And that's something that, you could consider, right, to try and mitigate your risk for heart disease.
Now, on that, because hormone replacement therapy has been in the news since the removal of the black box label, I think there's another restriction that if you haven't been taking estrogen and you're 10 years post the menopause event, there's cardiac risk to adding it later after 10 years. Can you explain that a little?
So I think that data is somewhat controversial, right? This is data from the Women's Health Study where they showed that when you replace estrogen, your risk of having heart disease goes up in your first year after replacement, but then goes down after that. So that's why people have always been hesitant to give estrogen supplementation. I think, there's many ways to give estrogen supplementation, and also estrogen dosages have decreased considerably from the days in which those studies were done. So I think that data probably needs to be revisited and restudied, in the modern era to try and see what the newer forms of estrogen replacement, do for you. Also, I think, for many women, it's not just about cardiovascular health. It's also about sexual health, right? And sexual satisfaction and all these things. And I think the black box warning shouldn't apply to, for instance, transvaginal or transdermal applications, which give you much lower systemic exposure to estrogen than, estrogen that is ingested as a pill, right? So I think that it's something that, again, depending on what your cancer is, right? So for instance, if you had an estrogen positive breast cancer, you probably don't want to be taking estrogen
Right.
supplementation
Right.
because it increases the risk of recurrent cancer. But if you had something else, where the chemotherapy destroyed your ovaries, you probably can take estrogen. So I think it's something that, one should have a conversation and probably get involved with someone who does, OBGYN or something or endocrinology where they have knowledge about how you could take estrogen supplementation in the least harmful way.
Well, it's interesting that you bring that up because you have a very unique specialty with cardio-oncology. I think for a lot of OB-GYNs or even endocrinologists, if they're not dealing with a population of cancer patients, people who have been in early menopause, I'm not sure they have the knowledge. Like, how do you find a doctor that, is actually equipped to care for people who are in a small subset population?
So again, like oncocardiology, which is a fairly restricted field and, unfortunately only available in large academic oncology centers, those places tend to also have oncofertility specialists. They tend to have oncoendocrinologists. So all these people exist. It's just that they're kind of siloed in the major academic oncology centers. But, as more and more cancer patients survive and, become a larger part of our population and larger uh, number of people that we care for, all of these subspecialties are increasing. So you could find these people. You're right. There are not many of them, but they do exist.
Yeah, I just think it's important for listeners to know it's probably not your standard OB-GYN or standard endocrinologist. If you are a cancer survivor, there's probably a specialist you want to have a conversation with.
Some standard OBGYNs and endocrinologists may be willing to, even look it up or something. So I think you could start there. But if they tell you that that's not something that they're comfortable with, then it may be time to go look for a subspecialist.
Okay. So let's go back to your screening, right? If someone's listening to this podcast and is about to start treatment or is in the middle of it, or even is post-treatment, what's the gold standard of monitoring, assuming that they're having a treatment that is cardiotoxic? Is it an echocardiogram, or are there specific blood markers like troponin or something else that they should be doing or asking for?
It really depends on what you're getting and what the cardiotoxicity of that particular cancer treatment is. So let's say you're getting anthracyclines or doxorubicin. That causes weakening of the heart muscle. So in those people, echo is the gold standard, right? And you do echo before, during, and after treatment. And how long after, as I said before, depends on your age, your cardiac risk factors, etc. If you are getting, Herceptin, same thing. Echo would be the basis for doing everything. But there are drugs that cause hypertension. There are drugs that cause high lipids, high cholesterol. There are drugs that predispose you to diabetes, heart rhythm problems, coronary artery disease. So really the screening depends upon what the toxicity is. So you can't say that the echo is the blanket gold test or, anything like that. It has to be tailored to what the toxicity of that drug is.
So it's important, I think, just have the conversation, know what the screening should be. And then it sounded like stay on top of it. Make sure that if the screening's supposed to happen, you're scheduling it, you're making it happen. Don't be passive.
Exactly. And I think one of the things that people don't appreciate and is very important, and this is true for both patients and oncologists, is that people who have traditional cardiac risk factors, whether it be high blood pressure, high cholesterol, diabetes, obesity, sedentary lifestyle, smoking, etc., are at higher risk for developing cardiotoxicity. And these risk factors have also been shown to increase your risk of cancer. So a lot of times when people are going through therapy, right, they tend to think, this is all I have the headspace to think about. I don't care what my blood pressure is. I don't want to take my cholesterol medications. I don't want to exercise, all these other things, right? And by doing that, they are sort of doing a disservice to themselves both from a cardiac standpoint and from a cancer standpoint. So one thing that I would say is uniform across any type of cancer treatment that you're getting is to make sure that your traditional cardiovascular risk factors are monitored and treated appropriately.
The rest of your body isn't on hold while you're facing cancer.
Exactly.
So let's talk about things you should be doing or could be doing while you're going through treatment or afterwards. But are there any things available that happen to prevent or minimize the damage? Are there medications or exercise protocols that kind of armor the heart?
So again, depending on what you're being treated with, right? But again, as I said, blood pressure control, diabetes control, cholesterol control, etc., all very good for protecting the heart, regardless of what you're getting. Exercise actually has been shown in many, many, many studies. If you exercise during cancer treatment, namely just simple walking, 5 days a week for 30 minutes, right? You have better mood, you have less fatigue, you have greater energy. And recently, there was a large trial that was published in the New England Journal, and this was done on colon cancer survivors who had completed cancer therapy. And they randomized them to structured exercise versus just lifestyle education. And the structured exercise group, interestingly, had a lower rate of risk of recurrent cancer or new cancer. They lived longer at 8 years of follow-up, right? This was called the challenge trial. So that was the first trial that has shown that regular exercise, right? And it doesn't have to be going to the gym or anything fancy like that. It could be something simple, can actually improve your likelihood of having recurrent cancer and dying from cancer. We've always known that exercise is good for heart disease, but now we know that exercise is also good for cancer. So I think that is one thing that you could definitely do for yourself, right? To help reduce your risk. Certain treatments like anthracyclines, again, doxorubicin, we do have drugs that can reduce your risk of developing cardiomyopathy. So statins, for instance, have been shown to be cardioprotective if you're getting high doses of anthracyclines. And it has been recommended that people take a statin starting with their chemotherapy. Similarly, there are specific drugs, something called dexrazoxane. There are specific formulations of anthracyclines, things like Doxil, that you can take if you are at particularly high risk of developing cardiomyopathy. So these would be people with pre-existing heart disease, people who are very elderly, where we know that their heart will not be able to tolerate this treatment. So there are options, but they're sort of reserved for the very high-risk people.
So to sum it up, everyone should exercise at least moderately. It helps with cancer. It helps with heart disease. It helps with mental health. It's basically a really good idea.
Exactly.
And if you are high risk, you already have cardiovascular disease, you're older, what have you, there are medications that can help mitigate some of this risk as well. What's the new baseline? What's the new maintenance protocols for people? Because now we have cancer survivors. I mean, my mother's 43 years, like 5, 10, 20, 40 years. What are you looking at in your research, and what are you seeing about how we think of cardiac health with long-term survivors?
So I think long-term survivors, there is natural aging, right? And with age comes heart disease, right? Your two largest causes of death as you age are cancer or heart disease. So unfortunately, we're all going to get one of them. So just because you had one doesn't prevent you from getting the other. So I think that, again, controlling your traditional risk factors, exercising, taking care of your body, right? It's what the AHA or the American Heart Association calls Life Simple 8, namely maintaining a good body weight, exercising on a regular basis, eating a diet that is high in, vegetables, fruits, legumes, all of that stuff, right? The Mediterranean diet, not smoking, not drinking alcohol. It used to be in moderation. Now they're recommending you don't drink it at all. Blood pressure control, cholesterol control, diabetes control, all these things. So I think those things not only reduce your risk of heart disease, but they also reduce your risk of cancer. So as you get older, that's what you have to do. You have to maintain a healthy lifestyle. There's no real rocket science to it. You just have to do all the things that we already know are good for us.
And hopefully we can make them fun. So tell me a little bit about what you're fascinated by and researching. What big questions are you exploring over at Dana-Farber?
So I think, there's always been a great interest in anthracycline cardiotoxicity, right? Because it is still one of the more common cardiotoxicities, and anthracyclines, even though they're really old drugs, are still very effective. So there's a lot of interest in sort of, tightening up or personalizing the surveillance a little bit better. The guidelines are very, in a way, onerous if you follow them for every single human being. So I think there's a lot of emphasis on trying to figure out who is truly at risk and how often should we surveillance those people, and, how to minimize, I guess, the burden that surveillance places on you, both mentally, physically, and economically, right? While doing it in the most effective manner and for the most likely to be affected person. So I think personalized surveillance is a big thing in cardio-oncology that's coming up, and AI will hopefully help us also figure out who is at risk and how to surveil those people. In radiation, I already told you there's a lot of interest in trying to come up with newer ways of delivering radiation so that the heart, et cetera, is spared. Immunotherapy is another big forefront, right? More and more cancers are now getting treated with immunotherapy. Immunotherapy works by basically unleashing your own immune system to attack the tumor. When that happens, you can have bystander, damage because your immune system gets so revved up that it can kill your heart, it can kill your adrenal glands, your lungs, any organ in your body, right? So how to best manage that? That's a big area of ongoing research. Who to re-challenge, right? Once you develop a complication, are you done with immunotherapy? Or can we somehow figure out who is it okay to go ahead and give immunotherapy to again? Because it is so effective, right? Another big area is, again, there's many types of immunotherapy as well, right? CAR T cells, immune checkpoint inhibitors, etc. What is the consequence of chronic low-grade inflammation in your body if you are being treated by these drugs for years and years, right? That's something that nobody knows. We know that inflammation promotes coronary artery disease. Does being on an immune checkpoint inhibitor increase your risk of long-term heart disease? So those are all questions that we are studying at this time to kind of keep up with the advances in cancer therapy.
Fascinating. All right, let's do some lightning round. So this is just quick back and forth. I ask a question, make a statement. You respond with the first thing that comes into your mind.
Okay.
All right. The metric that matters. If patients should track one number regarding their heart health at home, what is it?
Blood pressure. Blood pressure is the single largest predictor of heart disease, both cardiac disease, stroke, and heart failure. So if there's one thing you want, monitor and control your blood pressure. Ideally, it should be less than 130 for the top number and 80 for the bottom.
And if you have a elevated blood pressure, should you run to the ER or should you wait a couple days, see if it stays up? What does one do?
I mean, you should monitor your blood pressure on a regular basis. If it's high, maybe check it every day for a week and keep a log of it. And it continues to be high, then go to your doctor and tell them you have high blood pressure and they should put you on medication. Diet matters. You want to avoid salt as much as possible. You want to lose weight. There are many things that can help you with blood pressure. But blood pressure is probably the one single cardiac metric that has the worst long-term outcomes.
Okay. All right. What is the biggest misconception oncologists have about heart health?
Not paying enough attention to traditional cardiovascular risk factors while you're going through cancer treatment. I think people become very myopic and focus only on the cancer. And as you very correctly said earlier, just because you have cancer doesn't mean you can't have other problems. So controlling traditional risk factors is very important. So don't stop taking your statin just because you have cancer.
Yeah, I think basically don't change anything unless your doctor tells you to change it on purpose.
Exactly.
All right. So, a superfood or habit, is there one thing you'd love every cancer patient to do for their heart today?
Exercise. Again, not too much. You don't have to go crazy. Simple walking, 30 minutes, 20 minutes, whatever you can do, right? Ideally every day, but even if you do it 4 or 5 times a week, very, very important. Some resistance training, doesn't have to be anything major, even just lifting 2-pound weights or taking some bands and, doing a little exercise twice a week for 10 minutes. Very important for bone health. Cancer drugs do a number on your bones, especially steroids, right? They make you prone to osteoporosis, fractures, etc. Twice a week, 10 minutes of resistance training is very important for your bone health. So exercise is the one thing I would say is what you can do for your own body that has long-term consequences that are good.
I think my team was so elated. I came in already exercising and I said, so I lift weights 3 times a week, heavy, and I do cardio the other 2 or 3 days a week. And is there anything I should stop? They're like, please don't.
Yeah.
Keep going.
Exactly.
Was tremendous. I actually think, and I don't have any science evidence, but my recovery from surgery was really fast. And I had, a 14-hour surgery. But my recovery was fast, I think because my body was used to having to recover.
No, I think if there's lots of data, the better shape you go into cancer with, the more likely you are to come out in good shape. If you keep exercising while you're being treated, the less likely you are to fall apart, from a body standpoint. If you exercise after you finished, you do well in the long run, both from a cancer and heart disease perspective. So honestly, one cannot say enough about exercise.
Everybody, exercise. That's the big message there. Okay, let's do another question. What's the most exciting advancement in cardio-oncology that's emerging or exists right now?
Personalized approach to risk prognostication and monitoring and treatment. So I think one size fits all is like the way we've done it all along, and that's neither cost effective nor good for the patient psychologically. So coming up with a more personalized approach is the big advance in cardio-oncology.
Makes sense. All right. What is one thing you recommend for anyone looking to kick cancer's ass?
Be good to your body. Do one thing every day where you are consciously saying, I want to be kind to myself. Okay. So whether it's exercise, whether it's eating a nourishing meal, whether it's truly getting some rest for your body, but do something that is positive for your body as a whole every day. And, it's like that book, Atomic Habits, right?
Mhm.
The little things that are disciplined that you do in a regular way that really make a difference in your life. So maintain that routine of doing something that is good for you every day.
I actually took that and turbocharged it and said, everybody, when you're going through cancer, everyone says, how can I help? So I created a list of things that make me smile. A joke, a picture of your dog, a story about your kid, emoji, a meal. There's so many. I call them happiness tripwires. And I actually concentrated a lot of them on my infusion days, but they were happening other days as well. What an incredible boost, mood, focus, and immune system from not just being kind to myself. I love that advice, but actually inviting people to help me feel a moment, a millisecond of joy.
Yep. And I think that's very important. People underestimate that so much of your recovery is mental. If you have a positive attitude, positive things happen to you. If you have a negative attitude, it doesn't matter what's going on, you're going to feel badly. So I think creating that positive energy, even if it just means doing a chore that means something to you on a daily basis, just keeping that normalcy in your life is very important.
I agree. And adding it, like I think you can make your cancer year a year of a lot of happiness because people want to show you and tell you that they care about you, right? It's
Yeah.
if you choose to share it, it's a very intense episodic disease. So people like to do something for short periods of time.
Exactly. So take advantage of that, right?
Well, and it helps them and helps you.
I agree.
So, Anju, I really appreciate you talking with me and my listeners and showing the playbook that surviving cancer doesn't have to sacrifice your future health, even if you had cardiotoxic treatment. There are lots of options between screening, interventions, exercise that can lead to long, healthy, strong lives. And I think that's just such a powerful message. So I thank you so much for sharing it with us.
Thank you for meeting me. I really appreciate it.